as I understand. But please stick around afterwards if you have more questions or if you wish to talk with me or Anya. And so, let's see, I think I've said everything I need to say. Oh yes, and when you want to ask questions, please go back to the microphone at the podium. Don't just speak out from your seat. And now I'd like to introduce Dr. Jeff Hergenrather, who's quite an expert on cannabis medicine.
Thank you, Gail, for the introduction. Let me see if I can get some help in getting the link between the computer and this projector. Thank you. Okay, thanks. All right, for any of you who had heard that there was free marijuana being handed out tonight, I'm sorry, it's not that I know of, let me put it that way. All right. So, I'm really glad to be here, and I appreciate the turnout very much. I'm going to cherry pick some slides from my slide sets. I taught a course over at Sonoma State this year, and had to develop a set of slides for 15 different lectures. So I've got material on all kinds of topics, but what I wanted to do tonight was have more of an overview and cherry pick some of the things and bring in some of the latest stuff that I think is very interesting. There's also some historical information that I think you'll find valuable as well. To start though, I'll just say that I am a local practitioner. I practice about 200 yards that way, and I do see patients regularly for consultations and using cannabis, and I've loved this practice, and I've been doing it now for nearly 20 years. I left the Warwick ER back in 2003, but I really started my practice with cannabis in Sebastopol in 1999, and it's you, the patients, who have taught me about cannabis. And I think anybody who's going into this field has to realize that there's some basic science that is key to understanding what's going on, but really these individual experiences on cannabis as medicine is key to that, to the physician's education. So in general, I encourage people to tell their doctors about their experiences with cannabis, good or bad. Just tell them about it, because the docs need to learn from the patients, and they don't really get it elsewhere. We did mention that I'll take questions as we go along. I do feel that with the amount of material that I'm presenting, it's not going to be fair to try to hold a question until the end of the talk. So please feel free to wave an arm, and if you're loud, go ahead and sound off, and I'll repeat your question. Or if you're near the mic, go ahead and ask at the mic. That's going to be fine. So I do not have any disclosures to make to you as far as being associated with any particular companies or products. I have to make a point of doing it that way for my own reasons, but I do get asked to participate quite often in product development and company development. But the truth of the matter is there's a huge amount that we don't know. We know a lot, but when it comes to a plant with so many active constituents, it's really very, very complex when it gets into the interactions between these different molecules. So the history goes back a long, long time, and you'll see in this picture here, there are these green spots in the map, but also, is this a pointer as well? Yes. There's some orange ones out here that, and red ones that go out 10 and 20,000 years ago, where cannabis products have been found in the archaeological finds. So we know that this has been around for a long time. Yes, it's in the Chinese literature going back something like 3,000 or 4,000 years ago, but honestly, evidence dates back much farther back than the written evidence of cannabis use in the pottery and the fibers and even the pollen dating back as much as 100,000 years ago. This goes a long time back. And then in the European continent and North Africa, we see cannabis again dating back many thousands of years in the archaeological finds. So it has been around a long, long time. I do appreciate this quote by Herodotus, who said this somewhere around 450 BC. This was a very interesting report from Greece about the Scythians far to the north. And in the archaeological finds, they find these little teepees. They stand just a few feet off the ground, and what they would do is put their head under the teepee with an urn of hot rocks and cannabis. And as Herodotus describes, they take some hemp seed, creep into the tent, and throw the seeds on the hot stones, and once it begins to smoke, giving off vapor unsurpassed by any vapor bath one could find in Greece. The Scythians enjoy it so much that they howl with pleasure. Yeah, that's right. I'm sure they did. Cannabis is used as fodder. It's been used forever for this purpose. Animals eat it up. They get the cannabinoids in their milk, and they, anybody who is fed on those milk products is getting cannabinoids in that product. We make a big deal about the idea that a mother would be nursing a baby and having exposure to cannabis, which is just foolhardy and really quite cruel. That's another subject. Okay, cannabis is fiber. This is impressive. We get these long fibers, sativas generally, that grow quite tall, and they're a wonderful crop for fiber and clothing, such as the shirt I've got on tonight. Fiber and cannabis for medicine. This is a new slide I just got in LA a couple weeks ago. This is a field this year or last year, I'm not sure which, in Oregon. And this is a high CBD strain being grown in a vast field. They're really having trouble harvesting it because the regular combines get gummed up with the sticky oil. So they're having trouble figuring out how to best harvest this. But you can see it looks like it's doing quite well. This is all about this endocannabinoid system. The endocannabinoid receptor was first seen in 1988 when Alyn Howlett radioactively labeled a cannabinoid, put it into somebody's body, and it went to some receptors. And I'll show pictures of the receptors in a minute, but the point is, this began really unraveling a lot of the mystery of what cannabis was doing in the body. It went to these very specific sites in the nervous system and in the immune system. And the modulating roles that it has is something that I'm going to be teaching a little bit about. The endocannabinoid system goes all the way back historically to these hydra, still around today. Over the evolutionary time, this dates back something like 600 million years ago, that this endocannabinoid system has been part of the animal kingdom. We do know that about it, and that it has evolved along because it brings us into balance. It supports life in general. It brings us to the point where we eat and we sleep and we relax in an appropriate fashion to keep our bodies healthy. So this endocannabinoid system is all about homeostasis. There are a number of receptors in the body that have these cannabinoid receptors. This is the CB1 receptor you see here, with the hot spots being the reds and the oranges and the yellows. It's the most popular of receptors in the brain, actually. So it's well represented in the brain. And then the CB2 receptors in the rest of the body. This is supposedly an injection, but honestly it's not really an injection because it's already filling the liver. It must have been 5 or 10 minutes after. But as the hour and 40 minutes goes along, you see that the endocannabinoid system is active throughout the immune system and the liver, the spleen, the lymphatics, the tonsils, the thymus, the adenoids, and so forth. The immune system is rich in these endocannabinoids as well, again, because of the modulating role it plays there. And so, switching gears a little bit, we're looking at this plant because it's such a treasure trove of these molecules. When I first started in the practice, we were talking about 50 or 60 cannabinoids, then it was 60, then it was 70, and as of the research from a Dr. Miri in Israel just this past year, he's talking about 100 to 144 different cannabinoids in the plant. He can see them and he's separating them, and many of them are yet to be named. We don't have names for a lot of them yet. They're just a number at this point. So this endocannabinoid system is modulating nervous system and immune system activity. Its principal roles, as I began to speak of, are eat, sleep, relax, forget, and protect. Forgetting in a good way. This kind of calms the brain and settles you down and gets your job off your sleeve, helps you focus on things you need to focus on. The protective role is widespread. It's lowering intraocular pressure. It's downregulating pain signaling. It's actually doing all kinds of things. You can't fertilize a human egg without the endocannabinoid system working properly. It's throughout our bodies doing all kinds of things. In the nervous system, these slides you may have seen before, but the point of them is if a light, weak signal comes into one neuron and not much glutamate has been released into the cleft between the two cells in the brain or in the nervous system, then there's no signal going from one neuron to the next. But as the signal gets stronger, then we see that there's enough glutamate to activate this glutamate receptor on the opposite cell, and then that that will transmit the signal from one cell to the other. Now, when that begins to occur, your natural cannabinoids built in, represented here, are upregulated and begin to be produced. They cross the cleft in the opposite direction as the neurotransmission, and when they activate that CB1 receptor, the ones we saw in the brain a minute ago, it stops the release and production of the glutamate or any other neurotransmitter and calms the nerve down. So it's protecting the nerves from too much signal, which is called excitotoxicity. It damages nerves to fire them over and over again. So this is a natural feedback loop to protect the nervous system. It's supposed to be there to do that. It downregulates. It's supposed to downregulate. So when people get all excited about, oh, your short-term memory is impaired or your reaction time might be a little bit slower, well, this is what it's supposed to do. It's not abnormal, it's not wrong, it's not a problem, it's just that's what it does. Here's another neurotransmitter, GABA. This is an inhibitory neurotransmitter, very important in pain signaling. What we've got here, same effect, whether it's an inhibitory or an excitatory neuron, the cannabinoids are there to protect the nerves. This is a brief review of a couple issues in the immune system. It's much harder to characterize what's going on in the immune system. We know that it's a downregulating effect. We know that when experimental models are designed to see what happens in transplants, the THC as a single model protects the graft. So it has a valuable role in the host versus graft reaction. I've been hearing from patients for 20 years almost that the organ that they got in transplant is doing well, and the patient's doctors are saying, gee, you don't need a lot of immunomodulatory medicine or steroids because you're doing very well, just keep doing what you're doing. Many cases, the doctors don't know that the patient's using cannabis. Yes, your question?
I'm slow, so this is from a minute ago, but you said that there are hundreds of cannabinoids that some aren't even named yet, just numbered. By that, do you mean like THCA, THCV, CBDA, CBDN?
Yes, I do.
Yeah,
That is correct.
Okay.
And so the 100 to 155 different cannabinoids, 100 to 144, different cannabinoids. Many are named, but many are not yet named. And I'll show you an image that doesn't really do justice, but it points out the fact that there are many minor cannabinoids that have very significant roles that we're just beginning to learn about. This monkey study was really cool. They were injecting, first of all, they infected monkeys with an AIDS-like virus, the simian immunodeficiency virus. This was done down at the University of Mississippi. Half of the monkeys got a daily injection of THC. For those that did, the ones that got the THC, it ameliorated disease progression, attenuated viral load and tissue inflammation, significantly reducing the morbidity and mortality of the infected macaque monkeys.
Could you put that in layman's language?
Well, we don't know what's going on, but the virus didn't have as much damage to these monkeys. As it was describing, the viral load, the number of viral particles in the bloodstream was far reduced in the monkeys that were getting a THC injection. So there's something about the immune system that is improved with this cannabis effect. So it's not harmful to the immune system. It doesn't make you more prone to an infection, even though it's down-regulating your immune system. It kind of makes it smarter. Yes, sir?
You said it would protect the nerves. Would it help someone with MS?
Yes, very much so. It does help people with MS and other neurodegenerative diseases. Yeah.
Jeff, when you say upregulated or downregulated, is that a function of activation?
Question is upregulating or downregulating a matter of activation? When we're talking about a nervous system, downregulating would be calming the nerves down, reducing signaling. In the immune system, again, it's a little harder to characterize, but it's turning down the immune responsiveness. Like, we don't want our immune system to react to campfire smoke. If you breathe it in, you don't want to have an immune response to that. So there's some things built into our bodies that we don't really understand, and I would suggest perhaps that cannabinoids are protecting us from having an inappropriate immune response. It downregulates the response. Upregulating, on the other hand, may turn up a response. So this cannabinoid system that I was showing by the natural cannabinoid crossing the cleft, when it backs down and is quiet, that allows the signal to be stronger. So it goes both ways. It's either downregulating or upregulating the tone of the nerves.
Thank you.
Okay.
On your list there, that
Can we please use the microphone to ask questions so that people out here can hear what's going on? I know it's kind of bothersome, but it would really help everybody out there who's listening.
That's true.
That would be really awesome.
Thank you.
Thank you.
Or you could just repeat the question.
I can repeat questions as well. Do you have a hot question?
About this list that's...
Yes, this list on the board now, the question is about.
When you say, you're talking about cannabinoids as if they all do all this, but are there certain ones that do certain things?
It's a good question. The question is, do different cannabinoids have different effects as far as all of these pharmacologic properties? Yeah, I think we would have to say yes. Overall, cannabinoids are capable of doing all of these pharmacologic effects. So when we use cannabis and augment our natural cannabinoid system, we expect these pharmacological effects to occur with cannabis. We may find that some cannabinoids are better at it than others. For example, CBD doesn't work as well for pain or for sleep. But generally speaking, cannabinoids are upregulating the system. There are other cannabinoids in the plant that are mild blockers. So we have agonists and antagonists. It goes both ways. So these molecules work in concert better together than they do alone, and it gets complex. Not only because there's so many different plant cannabinoids that we're putting into the body, but there's a handful of different receptors that can take these cannabinoids. It's not just that CB1 or CB2 receptor. There's TRPV receptors and PPAR receptors, and I don't want to go there, but there's a lot of different receptors in the body that respond to the cannabinoids. Let's leave it and go on. Modulating endocannabinoid activity, which is what we do when we're using cannabis, this is out of the NIH 5 years ago, may have therapeutic potential in almost all diseases affecting humans. Blah, blah, blah. Strong words out of the NIH. These are doctors that do not have anything to do with cannabis. They are really seeing these cannabinoids as coming to you as new drugs from the pharmaceutical industry and not as cannabis. But we know that we can do all of these things with cannabis. By the way, and I don't know how best to do it, Gail, but I wouldn't mind sending the slide set to people if they want to leave me a business card or a note with their name and email on that.
Dr. Hergenrather, we could post it on our foundation Facebook page.
Okay, we can do that. So we'll post it on the foundation Facebook page, and people who want to get this slide set, I'm happy to send it. This is for everybody to know.
We're also broadcasting on Facebook Live, so you'll be able to look at it later.
Oh, great. Good.
Thank you.
Okay, I'm going to go on to a little bit of biochemistry for a moment. this is what is thought to be this cannabinoid receptor I'm talking about, the one that's anchored through our nervous system and immune system. It's a string of amino acids, 472 on the CB1 receptor, the blue dots, and 360 on the green dots. This is the CB2 receptor. So these receptors are made inside the cell. They migrate into the cell membrane, and when they reach the membrane, they're there like a socket. And they're ready for the natural cannabinoids to fit into the socket and activate it and cause those various pharmacologic events to occur. So when we use the cannabis, we're doing just that. We're augmenting that effect. Now, the other thing I want you to appreciate about this is in the basic science, if you change one amino acid in that sequence, you can have a measurable difference in the function of the cannabinoid receptor. It does not work as well. So in genetic testing today, we look at the genes that make these receptors. And what we can see is that the genes are not the same from person to person. These are called polymorphisms of the CB1 receptor, different forms of the CB1 receptor. And the very interesting thing about that is, if we look at various conditions, medical problems, that in the past we've just said idiopathic, we don't know the cause of it. Now we can say that these may be endocannabinoid deficiency syndromes, and it's implicated now in schizophrenia and migraine and MS, Huntington's, Parkinson's, irritable bowel, failure to thrive in infants, anorexia as a chronic problem, chronic motion sickness, fibromyalgia, menstrual symptoms, seizure disorders, even happiness has been seen as a polymorphism of the receptor. It's rather fascinating that it affects our moods in this way. It goes all the way to the end of the list with other somewhat more obscure things. But the point is that subtle differences in our receptors make us more prone to diseases or even happiness. So it's not only diseases, it's just the way our bodies work. Now, this is a rank order of the conditions that I'm seeing in my practice, and by far pain has been the number one condition that I've been treating for all of these years. Probably something in the order of 50% of my patients come with chronic pain. When you augment that natural cannabinoid system, it's down-regulating that pain signaling, and people get a benefit. When we take cannabis and opioids at the same time, we get a very good benefit. First of all, you don't need as much opioid to get the same pain relief. And secondly, you don't have the same tolerance developed to opioids when you're using cannabinoids. So it makes a nice substitute. It's not a pain reliever exactly. It is a pain reliever, but not with the potency of opioids. You can stop pain with opioids, but they also have a lot of downside to them. But in conjunction with cannabinoids, it's very effective to use them both. And for many, many patients, I see them exiting from opioid dependence away from opioid use, at least on a regular basis. Very helpful for this opioid epidemic.
Excuse me.
Yes, ma'am.
Do you have time in this lecture to talk about particular, like, I'm interested in knowing about dementia.
Mm-hmm.
I refer dementia patients to you. I'm a social worker, and so I'm interested in knowing more about how that
Well, the question was about can we tease apart some of these different conditions and talk more about them? I think we're probably going to run too long overall, and I don't mind taking questions as long as they'll let us stay in the room. So I'm happy to carry on. It's very useful in dementia, just in a word. Cancers, this has come up the list for me. When I first started my practice, I was seeing about 8% of my patients had cancer. Now it's probably 35%. So people are coming in not only to mitigate the symptoms of cancer, the anorexia and the pain and the mood issues associated with it and the insomnia and on, so many symptoms, nausea and vomiting or chemotherapy, but also simply because it does slow the progression of these cancers in many, many cases. And in some cases, I'll show you a couple of examples, it stops cancers. So this is a very important use of cannabis. Mental disorders of all kinds. And, people make a big deal about, we don't use cannabis for schizophrenics. Well, No, that's not true. I've got schizophrenics that really like cannabis because it gives them a little holiday from their schizophrenia. It doesn't stop it. It just gives them a lighter heart and a little relaxation about the psychosis that they're dealing with. Some people don't do as well with it, but it's not, in my mind, it really isn't prohibited from use from any kind of mental disorder. About 30% of my patients have some reported anxiety, depression, and so forth. GI disorders, this includes the inflammatory bowel diseases do very well with cannabinoids. The GI tract is loaded with receptors, and so when they're activated, it slows the gut down, reduces the contractility to where there's less pain, so irritable bowel is eased. It helps with reducing stomach acid. It helps with esophageal reflux, and so forth and so forth. Many people benefit with gastrointestinal problems. Insomnia, CBD isn't great for that alone, but THC is and has been used for many patients that I treat for a long time, and using it at bedtime is very helpful. Migraine, harm reduction, I've spoken a little bit about already. Spastic disorders of any kind, again, interfering with this cannabinoid transmission into spasm. If we can calm those nerves, people's spasms stop with one puff, if you will. Jonah?
If I was arriving from Mars and listening to you now, I would say, this sounds like a miracle drug.
Dr. Raskin says that this would sound like a miracle drug if you were coming from if you're coming from Mars, right? And yes, it would.
Dr. Hergenrather, I have a question.
Yes, go ahead, please.
Does the THCA version, do you have to have more of it since it's not been decarboxylated? Does it work as well for all of these?
The question is a good one. I think I don't really have a good answer. THCA has not been studied nearly as much as THC. THC acid, I'll show you a picture of it in a minute. It's the green form of cannabis THC. So when the plant's alive and well and growing, most of the THC, not all of it, is in a THCA form. And we don't even yet know how well it crosses the blood-brain barrier. We don't know if it actually activates the cannabinoid receptor, but it kind of seems to. It's a bigger molecule. It probably doesn't. Well, I don't know. I don't really know the answer to that. But in general, because you don't get high with THCA, it's a little harder to tell how big an effect you're getting. So if you're looking for a very specific effect, you may or may not get it with THCA. When adding it to anti-seizure, anti-epilepsy drug treatment with THC and CBD, sometimes adding THCA is very helpful to improve the efficacy of the cannabinoids. You had a question?
Yes, why does cannabis cause anxiety for some people?
Question is, why does cannabis cause anxiety? It may be that there's what we would call a biphasic effect. What I think more likely is, and I'll describe that response a bit further in the talk, but I think that people get unnerved by having their brains work differently. And when you're subtly relaxed and, find things humorous and so forth, you feel good, it can be very soothing. But if you get really unhinged by a big dose, often that causes people to be panicky and anxious. So it does go both ways. Next is, I am asked all the time to help people select cultivars. What's going to work best for my condition? If it were only so simple. It just really is not that simple. I think what has been, and part of the problem is this. The federal government doesn't really allow us to do the randomized controlled trials that we would like to do, to take a plant product and say, okay, we're going to test this with so many people with this condition and see what the effect is. Or maybe compare several different strains of cannabis and see what works best. We can't do that in the United States. Generally speaking, it's almost impossible. So what we're dealing with is patients get a good response. And if you know that you're getting a good night's sleep when you take a dose of Blue Dream cannabis, then we want to know about that. And so we'll go the other direction. You know, the patients are going to have to drive the research in the United States. In other places in the world, research is going on, but the United States is pitifully behind on this. It's not that we haven't funded research. We fund a lot of research, but it's all about drug addiction. So the differences in the clinical effects from one cultivar to another is in part this different ratio of cannabinoids, but it's also these other molecules that I'm speaking of. Terpenes and flavonoids also are pharmacologically active and make a big difference as to what effects you're getting. If you take any one of those terpenes, and there may be as much as 150 different terpenes in a cannabis plant. So let's take the top 10. If you took the top 10 terpenes in the cannabis plant, there are all kinds of pharmacologic actions, from anti-cancer effects, anxiolytic effects, pain-relieving effects, anti-malarials. The list is long, and all these various effects can have a compounding effect in the way that the cannabis is working when it's taken as a whole plant.
What is a terpene?
A terpene is a small molecule that's kind of like a precursor to cannabinoids. It's a smaller molecule. It gives the plant the fragrance that it has. Cannabinoids are odorless and colorless. It's the terpenes that give it its fragrance. So they have names like limonene or pinene and so forth. You get the point. Things that you smell in the environment. Animals make terpenes as well. Mostly they're plant-derived, but when you smell lavender, you're smelling terpenes. When you smell lemons, you're smelling limonene. When you're smelling oranges, you're smelling nerolidol. It's another terpene, and so forth. So these terpenes have pharmacologic actions, and when they're there in big enough doses, they have a significant effect on the way that the cannabis affects us. Processing cannabis knocks out a lot of the terpenes because these are very volatile, smaller molecules. If you smell them, you're losing them. So if you're processing cannabis, if you're drying it for a long time when it's quite fresh, very fragrant. If it's a year old, it's not so fragrant anymore. You've lost a lot of your terpenes. If you're taking it in alcohol and extracting these molecules, and then you're boiling off the alcohol, you're boiling off the terpenes. So most of the oils that end up in vapor pens or in various foods and brownies and cookies and all kinds of things, you've lost a lot of the terpenes already. So if you really want all the terpene effects, and most people wouldn't know if they want them or not, you've got to vaporize it or smoke it to get them into your body. They're measurable, they last about 10 minutes, and then they're metabolized by the liver.
What about raw ingestion?
Raw ingestion, same thing. You're getting the terpenes, but you're also getting these acid forms.
Oh.
So if I'm saying there's 144 cannabinoids, double it, because there are acid forms of all of those cannabinoids. So you really have twice as many active molecules than that 100 to 144. So one strain is not necessarily exchangeable with another. This is an error that was made by our U.S. Supreme Court about 15 years ago when a lady named Angel Rach asked the courts if she could grow her own medicine because it worked so well for her pain. She wanted to legally be able to grow it. And the Supreme Court said, nope, it's a fungible crop. Fungible means you can't distinguish one cannabis from another. The jargon came from the wheat industry, and there is a time, it may even still be on the books, people can't grow their own wheat because it competes with the wheat industry. And so the Supreme Court said that wheat's a fungible crop, and your wheat is no different from the wheat being sold on the market, so you can't compete with them. So that's what a fungible crop is. They said that about cannabis, and it's not even close to true. Not even close. THC and CBD ratio, this is a good starting point to figure out what's going to work with a strain. We know that CBD is not psychoactive. THC is. So if you don't want to get high and you want to see if cannabis is going to work, you might try a high CBD strain or one more balanced in THC and CBD. So it kind of narrowed the field down to saying, let's look at the THC and CBD quantities and ratios in the plant. And that's a good start, but it's not the whole story, and I'll show you what I mean coming up. We have type 1 plants that are the regular marijuana. It's about 100 to 1 THC to CBD. 100 parts THC, 1 part CBD. We have those plants that are these type 3s down here that are about 20 or 30 to 1 CBD to THC. This is much closer to what natural hemp is like. And then there's a handful of strains in between that are about balanced, maybe 1 to 1 or 2 to 1, one either direction, where they're more or less equal in THC and CBD. These are very useful strains, but you can also blend them. You can take a high CBD strain, a high THC strain, put them together and have something balanced. So a lot of times I might tell somebody who really needs to treat something, use a CBD strain in the daytime when you're going to need to be on deck, cogent, driving, picking up the kids, doing all the things. But when you get home, then is a better time for your THC dose, or especially at bedtime when you're going to sleep through most of it, unless you like it. Hemp, the difference between hemp and type 3 cannabis is hard to define. There's not a clear line to where, okay, that's hemp and everything else is CBD-rich cannabis. It's not like that. It's really a continuum. So we do know that in order to be in the marketplace, dried hemp has to have less than 0.3% dry weight THC, and then it's called hemp. And if it's 0.4%, it's called marijuana. So that's the way the feds look at it. Yes?
I have a question. Recently I read that the roots of the plant are medicinal and that they are really good for anti-inflammatory use. Do you know anything about this?
The question is about the use of cannabis roots and their anti-inflammatory or other beneficial effects. Dr. Russo has done a paper on the subject, and it's quite interesting. I think the amount of these molecules is very, very low in the roots. So I wouldn't expect a significant effect, honestly. Certainly worth a try, and I'm all for using the whole plant, whatever that means. I put this slide in just because there are some issues here that I think are worth talking about. We have an entourage effect, meaning that all of these molecules together work differently and work better than they do individually. This whole reductionist idea of pharmacology to isolate one molecule and there's the medicine. It's not really the way it works with cannabis, because we know that the whole plant works much better than the individual molecules. Uniformly, when tested against people's medical issues, they choose the whole plant. Minor cannabinoids, I'm going to get into this in a minute to show what I mean by this, but again, these are some of the cannabinoids you don't hear about, the CBGs and the THCVs and on and on and on, and all these acid molecules as well. These other molecules have pharmacologic actions that are very important, and again, in concert with other cannabinoids, work quite a lot differently and better than they might alone. Synergy, when we take one molecule of a molecule such as THC and put it into a broth of cancer cells, it'll kill a certain number of them. And if we do the same with CBD, it'll kill a certain percentage of them. But if we put the two together, it kills almost all of them. So they work better together. This is the synergy of these molecules. Biphasic response, I'll show you a graph in a minute. Metabolic variations, I'll also show a graph. And then for cannabis as an adaptogen, this is a word that the naturopaths use, and I think it really applies. The point I like to do is this. If you take cannabis at bedtime and it helps you sleep, you're going to go, oh, that's great, it makes me sleep. If you use the same plant at 9 in the morning when you get up and get going, it's not going to make you go to sleep. It's going to do something, but it's not going to make you go to sleep. Same thing goes for eating. If you're kind of, end of the day and you don't quite have your appetite up and use cannabis, it's going to enhance your appetite, make the food taste better. It's great. You're going to eat well. If you've already had your meal and you use cannabis, well, you still might go back to the kitchen. It's an adaptogen. You get what you need It exerts a normalizing effect. It doesn't drag us. It's not compelling us to do things. Here's some of those terpenes. Pinene, bronchodilating, anti-inflammatory, acetylcholinesterase inhibitor. This is one of the benefits as far as Alzheimer's dementia. Limonene, anxiolytic, antidepressant, kills cancer cells, sedative, and anti-anxiety. So this is just 1, 2, 3, 4, 5, 6, 7 different 7 different terpenes. And again, I mentioned there may be as many as 150 different ones in the plant. But we like to look at the dominant ones because when they get up to a certain milligram amount per gram of cannabis, then that's a big enough dose to have a pharmacologic effect. Praising the entourage effect. This is a paper that I wanted to throw in because it came out in June, and I know I haven't showed the slides here, but what this was about is a research program in Madrid, and Manuel Guzman and his team have been studying cannabis effect on cancers for 20 years, and he has a great team and a great lab, and what they did in June was published a paper using cannabis as a whole plant extract to see how it would affect breast cancers. And they looked at 3 different types of breast cancer: the hormone positive, the HER2 positive, and the triple negative. And in looking at it, they produced these graphs, and I want to show them to you because I think they're very interesting. This is looking at a estrogen positive cancer, estrogen positive, progesterone positive breast cancer. And at the top here, what we're looking at is tumor volume, how fast this tumor grows. And on the bottom line, we're looking at 30 days. So this is making this tumor grow as rapidly as they possibly can by nutrients and so forth. And then they're adding different things. So on the clear dots, there's nothing but the vehicle. On the green dots, that's the THC alone. So it didn't do much, if you see what I'm saying. Here's a whole plant cannabis drug preparation, and it puts the dot down here. With tamoxifen, a hormone blocker, and that's where you get the leverage with a breast cancer that's estrogen positive. You stop the estrogen, the tumor responds and slows down. There's your response to the tamoxifen right there next to the cannabis. But you put the two together, the cannabis and the tamoxifen, and you get the best response. They work better together than they do alone. Yes?
Question about the terpenes. They get added to oils for vape cartridges. Does that mean if they have specific applications, could they be extracted and used specifically?
Yes, they could.
Huh.
Terpenes can be used in an isolated fashion that way. Certain strains will have certain profiles. That's what gives it the fragrance it has. So our local company at Cannacraft is making all kinds of vape oils, and what they've done is they've put it all through a still and separated it out, and at the end of the day they have a beaker of cannabinoids and a beaker of terpenes. Put your nose up to the beaker of cannabinoids, it doesn't smell like anything, and you put your nose up to the terpenes and it smells like cherry pie or blue dream or whatever it came from. So they reinfuse them into the cartridges for the vapor pens so that people actually have an experience that is similar to what the plant was like.
But there would be specific health applications depending on the
Yes.
terpenes that are chosen, right?
There are specific health applications to these terpenes, and if they were used, we get into, the industry gets into the idea that we can be a little smarter than nature here, and adding them in ways that I don't know what we're going to end up with. There are unknowns in manipulating these molecules. Gail.
I've got a question about mixing tamoxifen and cannabinoids. I've got several patients of my own. I'm a therapist who have cancer, prostate cancer, breast cancer. Is there a formula that's best for combining those two things?
Well, she asked if there's a formula for combining the terpenes and the cannabinoids in a best way to treat any particular, in tamoxifen, here we're dealing with breast cancer. I don't think we're quite there yet. I'll show you a slide in a minute because I think we're going to be able to personalize cancer therapy going forward. And so I'll show you what I mean with a couple slides coming up shortly. The next slide here was with lapatinib and cannabinoids. This is a drug that works on this HER2. And again, you see at the bottom, the combination of the drug and the cannabinoids works as well as the cannabis alone, and very similar to what the lapatinib did as well. So again, the cannabis works best with the chemotherapy. And we've seen this in other chemotherapy like gemcitabine, a common chemotherapy agent. So if you use it in conjunction with cannabinoids, you do better in treating certain cancers. And I think we'll see that across the board. It's true in the drug commonly used for the glioblastoma. I'm sorry, I'm forgetting about the name at the moment, but it'll come to me. Yes?
Lapatinib?
Yes.
So you're not mentioning here the Herceptin. Is that a reason for that?
This is what the research team tested.
Okay.
It's a good point, and it would be curious to see what that would have done. Here's one more graph. This is the triple negative. Now they're using a more common generic chemotherapy, cisplatin and cannabinoids. And again, right at the bottom, you got the red one. The combination of cisplatin and the cannabis extract are doing better in keeping this tumor from growing than any of those other individually. Yes?
Did they do any work in this group? You got this data from. Did they do any work toward trying to tease out the impact that the stress reduction, the calming effect might have? Because I've been through some of this.
Well, the question is about what about the calming effect of cannabinoids in terms of its therapeutic effect in treating conditions. These were specifically about breast cancers, but yes, I don't think we want to underestimate the relaxing benefits of cannabinoids. It's really another subject. Ladies, yes?
Is this paper available?
Yes, it is available.
Could you put a reference up for it?
Yes, well, there's the Blasco Benito 2018. If you Google that, you'll come up with the paper. That's a woman in that research team. Yes?
Were those cell line studies or human studies?
They were human tumors that were used in, I believe they were putting them into mice in order to grow them. Yeah. Moving along. I'm going to throw a case report in to catch your attention here. This is an autistic kid that I saw from Sebastopol. Started out as a 16-year-old that mom brings him in. He's a big boy now. He's 160 pounds and he's beginning to hit, shove if he doesn't get his way. She says open-handed, so I was comforted by that. He's not slugging. But he's a big kid, and she admits to me that it's getting scary now. Because, when he's not getting his way, he's very upset and he's a bit scary. So we got him started on cannabis. He said he has become increasingly aggressive with some open hand hitting, anxious, agitated, very disconnected socially. Has marked challenges with language, poor speech and comprehension, unable to read or write. Basically, he sits in the corner and doesn't do much all day. It's kind of a sad picture. Now the story goes here. Now, he's a lovely, happy, healthy, more socially engaged kid. He's no longer aggressive. He's docile and very helpful around the home. She says more helpful than his siblings. So he's really participating in the home now. He's expressing to mom his appreciation for being at home. And she finally gets down to this point, he's no longer dangerously impulsive and doesn't need constant surveillance. Big deal for families with an autistic child. It still amazes me that a week after we started cannabis, he completely started reading everything. And then from that point, he started writing and texting. And so now he's communicating in a way that he had never done before.
What's the CBD to THC ratio?
I encouraged him to start with a THC-CBD ratio of 1:1. She may have started it that way, but she kept getting all the bad news about THC through the media, and she went to CBD only. Well, not only. Dominant CBD, type 3 CBD, and it's working pretty well. But in our discussion a couple weeks ago, she said she would like to do better, so I've encouraged him to work a little more THC back into the formula for him. But he's a sweet kid and doing very well, and this change with his ability to learn is quite remarkable and not unique to him. He also manipulates numbers in a way that's kind of remarkable. Mom will say something like, "Oh, we were thinking of going next summer, maybe in July, there's a Saturday," you know, he'll tell her what date it is, or, you know, he's just, he's got numbers down. Yes?
I just wanted to ask a question about the dosage for him, and I'm assuming, is that a tincture?
Yes, it was done as a tincture, and dosing was the question. What about the dose and getting this response? I usually start people off with just a couple milligrams. If I'm doing a blend of THC and CBD, let's say even proportions, I might start off with something that I'm pretty sure they're not going to feel, which would be about 2 milligrams of each, and encourage them to keep increasing the dose up to 5 and 5, or maybe as high as 10 and 10. What I find at Primrose over on Guerneville Road, we're involved in helping folks there. The majority of those patients are on 10 milligrams of THC, 10 milligrams of CBD per dose, 1, 2, 3, maybe 4 times a day, depending on their situation. What I want you to understand is that in some patients, we need to get up to 30 and 30 to get an effective dose. Some people are much more resistant to these cannabinoid effects, and you've got to go way up on dose to get the effect. You'll get it. You just got to be comfortable with going up on dose, and then it does make the difference. People get docile, the aggressive behaviors fall off, and their anxiety falls off, the pain gets better, they sleep better, and so forth. So we'll set a dose where we might say treat with 10 and 10, maybe 2 or 3 times a day, with an added dose as needed for agitation or insomnia. We can add more medicine that way. If we're dealing with a high CBD, we might start off right at 10 milligrams and go up to 20 or 40 or 60 or 100. The autistic kids in Israel, which is what I'm going to tell you about next, are being treated with 300 milligrams of CBD per day. So our new great, everybody can go into the dispensary now, is prohibitively expensive to have that kind of a dose. We're talking a whole bottle of, an ounce of tincture a day would be a dose. It's currently priced at about $75. You just can't do it. You got to grow the plants yourselves or figure out some other way to get the cannabis.
I have one question.
Yes.
I'm going to get off the floor because
Go ahead, thanks.
But I want to ask, I know this isn't quite the right spot, but the isolated CBD that's coming from I don't know
Asia,
where.
Europe, wherever it's coming from.
I want to know your opinion because I just got back from the MJ BizCon and everybody's selling this stuff, and I don't know that it works. So I'd love to hear your opinion.
Well, I'm a little nervous about the CBD source from overseas. I don't think we have enough answers as to what it is. Is it what it says it is in terms of cannabinoids? What about pesticides? What about heavy metals? What about, the list is long as to what might be there. So it makes me a little nervous. I'd much rather source something that's grown in the United States, up in Oregon, wherever, where we are growing plants organically is the idea, and whole plant extracts. When we get these plant matters that are coming from Asia or coming maybe from Eastern Europe, they're often byproducts of the fiber industry or something else. So they're not really being grown for medicine, I would guess. I may be wrong about that, but I think that's probably true. Yes?
Do you have any preference between indoor and outdoor grown?
The question is, do I have a preference of indoor or outdoor grown? I always favor outdoor. I've been growing it in my yard forever. These kids were doing great. They came into the program with a lot of trouble, a lot of behavioral problems. They came in at 5, and then summing them all together in November of 2016, they were doing pretty well, and then suddenly they were doing badly, and the caregivers at the same time said, "What'd you do? It's not working." This is CBD, again, a type 3 cannabis with 100 cannabinoids there. The predominant cannabinoid is CBD. And the behaviors got bad. Caregivers were getting injured and ended up in ERs because of the violence in these kids. So they took this strain to the lab And Dr. Meary found that what was going on was strain 266, the column on the left and on the left, was the strain that was working. And 267 was the strain that was not working. So you see here the CBD was almost identical, the THC was almost identical. On the surface, it would appear to be the same. But obviously it's not. Look at the difference. There's a huge difference in CBGV and in CBDV and in this 7-hydroxy CBC, and here's another V, CBCV, and down here we have CBEAV. These are varin molecules. What varin molecules are is they have a short chain. Here's THC on the upper left, here's CBD next to it. We've only opened the ring by moving a hydrogen atom from that point there to this oxygen molecule, atom I should say. And when that occurs, the ring opens, it changes the shape of the molecule. It gets into the receptor, but it doesn't activate the receptor. THC gets into the receptor and it activates it. CBD works in a different way altogether. But look at what the varin molecule is. THC varin looks identical to THC except for the length of the chain. It's like the length of the key into the socket.
Oh.
So the varin molecules actually act like mild receptor antagonists. They kind of clog it up a little bit. But for whatever it was doing in those varin molecules shown here, it seems, one might guess, that the varin molecules were important in this CBD medicine working well for the kids. I'm guessing. We don't really know. Here's the deal I was talking about a few minutes ago. Cell viability, brain tumor cells grown in test tubes. We've added THC to this column, and it knocked off about half of the cancer cells. If you give a bigger dose of THC, it'll kill all the cancer cells. If you give a lighter dose, the column's taller. Here's the CBD added to this black column over here, and you can see it knocked it down about a third.
Wow.
Now you put the two together, there's the response. So this is that synergy of the two molecules. It's only two molecules. Probably works better with the whole plant extract.
Excuse me,
Yes.
why doesn't everybody do it who has a glioblastoma?
They're in a clinical, the question is, why doesn't everybody with glioblastoma use cannabis? I'm working on it. GW Pharmaceuticals, that makes a product that's 1-to-1 THC to CBD, has a clinical trial ongoing. They've extended it because people are living. So it's a big deal. They haven't published the results yet, I think because they can't stop. People are alive and they weren't before. My first GBM case was, I believe it was 15 years ago, and the guy came to me and said, glioblastoma, had surgery, chemo, radiation. Then he went and just started smoking pot every day, 3 times a day. Came to me 3 years later and said, the docs tell me there's no recurrence. I'm smoking pot every day. What do you think I should do? What can I do other than smoke? I say, sure, you can use tinctures, you can use oils, you can use other methods. And so he lived well with daily use of cannabis, unbeknownst to me. Alexander knows this story. He stopped using cannabis, and within a year he had a full recurrence. 9 years after. Why did he stop? I don't know why he stopped. He probably thought he'd killed it and didn't need to use it anymore. So he's lost a follow-up. Yes, sir.
So if you use half, and it kills half of the germs, and then you use the other half, once it's all gone, is there any danger of side effects from giving it more when they don't need it?
Well, I think you're asking, is there a side effect to using cannabis if you've killed the tumor?
Yeah.
And these molecules are remarkably safe. They're mimicking molecules in our body that bring us back home. So if you get brought back home really hard, you'll sleep. It won't hurt you. You can't kill yourself with these. And a good portion of the rest of my talk is based on what about these assertions of harm? So bear with me because we're getting into that in a minute. This is cancer cells growing in petri dishes. Now we have colon cancer on the top line, breast cancer on the second, prostate cancer on the third, and a control on the bottom line. And to those, we're adding about 1 microgram per milliliter dose of cannabinoids, whole plant extracts. I don't know which plant. But you'll see here that extract number 1 was mostly THC, low CBD. And it killed most of the colon, most of the breast, but didn't do so well on the prostate. The second extract was a high CBD strain, low THC. It killed most of the cancer of the breast, of the cancer of the colon and the breast, but again, didn't do so well on the prostate cancer. And then the third on the right is another CBD-rich extract. Again, I don't know what's different about these strains, chemically speaking, but it didn't do anything for the colon or the breast cancer, but it killed a lot of the prostate cancer. So again, this is complex. There are a lot of molecules that we haven't really identified their roles yet. And so I do have a slide to bring us to that. This is Dr. Mary, whose name I've mentioned. He's running the lab at Technion, which is a cancer institute in Haifa, Israel. And what he's done is said, okay, if we know that these extracts will kill these cancers, let's try to figure out what's different between these different molecules. So he began to isolate the molecules to see which ones were necessary to get the kills of those cancer cells like we saw here. Now the LCMS is the machine we're talking about. It's a liquid chromatography mass spectrometer. It's a coil that's heated. You squirt some of the cannabis extract into it, and as it's heated, it sorts out the molecules as they go through the column. Basically, what's happening is the lighter molecules come out first, and then the mass spec will make a peak where that came out. And then the next molecule, and another peak, and the next molecule, and so forth. And so you get this chart of all of these molecules that came out. Well, what he began to do was he isolated them and said, okay, I'm going to divide all the cannabinoids into these different segments. And I'm going to take the ones that come off first, and I'm going to isolate them and see what works. And then I'm going to take the second segment and isolate them and see what works, and so forth. So what he finally came down to was that if he took THC and CBD and added one other molecule, I know you can't read it, but it is molecule 331.B18. When he added that one to the other two, it killed the cancer cells. So I said, okay, we're all going to be looking for 331B18. Where can we get it? And he laughed and he said I was only joking, but he wasn't joking. This is kind of the state of the art. We're just getting to this point of trying to figure out what works best and which strains are going to have these particular molecules. Pretty exciting. I didn't know where else to put it, so I threw it in here. And this gets into the question about what about these CBDs coming from Asia or wherever. What this is about is that there's two graphs on the left and two graphs on the right. The ones on the left are with CBD as a single molecule. And the ones on the right are with CBD as a whole plant extract with all those other molecules. And what the test is it's taking a rat, I believe. They burned the paw. They knew they were going to get inflammation and swelling and pain. And so they measured the effect of CBD as a single molecule and CBD as a whole plant extract. And here's what they found. That if they gave a certain dose, it didn't do much for the paw thickness, the swelling. And as they gave a bigger and bigger dose, now we're up to 5 milligram per kilogram, you got the best response. The swelling was diminished the most. But as you went up on dose of single molecule CBD, you lost it. And the effect went away. It started swelling more. The same was true with pain. And this is a paw withdrawal test to see when the animal shows that he's either out of pain or in pain. And we again had a bell-shaped curve. It got better, and then it got worse. Whereas, when we did it as a whole plant extract, the bigger the dose, the less swelling. The bigger the dose, the better pain relief. Kind of an elegant test to show that the whole plant works better than the individual molecule. We all have a different liver, and they ain't the same. We have different metabolic enzymes in our liver. These are called generally the cytochrome P450, or the biggest system in our liver for breaking down molecules, whether it's from drugs or for foods or for cannabinoids. They're all metabolized by this system called the cytochrome P450 system. This is just pointing out some of them. What we want to know is that, are there any drug-drug interactions between regular medicines and the cannabinoids? Well, the only one that really sticks out as a problem is one called clobazam, which is in brand name Onfi. It's an anticonvulsant drug. When you give a dose of Onfi and you give CBD in very high doses, they're both trying to get broken down by the same pathway. It causes the clobazam to go up to a toxic level. So you've got to measure that one and get your blood level checked if you're on that particular anticonvulsant medicine. Otherwise, there are no significant drug-drug interactions between any pharmaceutical and the cannabis. It's pretty safe in that regard. A couple graphs. This is the difference between smoking or vaporizing, and the next one is ingesting. Very different curves. When you smoke at 0 minutes, or hours I should say, and here's your blood level on the left. You get a rapid peak in about 5 minutes of the THC. What it's getting broken down into is this solid line, this molecule called carboxy-THC. There's an intermediary between the two that the liver produces called 11-hydroxy-THC. It's also pharmacologically active, and it's produced by the liver, and it circulates in the bloodstream, and it does all the things that the THC does as well. The point is, after about 10 minutes, this peak begins to fall rapidly. By an hour, you can see that there's not a lot left. By 3 hours, it's pretty much gone. So it's a quick metabolism when inhaled. When we look at the ingested forms, we don't start doing anything for about a half hour, and then the fully metabolized one starts to show up. The liver's very efficient at this. It knocks these molecules down. Here's your THC is the lowest of the graphs. And then the second one is that 11-hydroxy, peaking at about 2 hours. So this is the tinctures, the brownies, the cookies, anything ingested. It's going to have a long duration of action running out 6 or 8 or 10 hours. So I'll tell people, I don't know if you're going to need to take this medicine 2 times a day or 3 times a day or 4 times a day. Depends on your metabolism. They're different from person to person. Some people are going to be done in 6 hours. This is an average of 6 patients. Some are going to be done at 6 hours. Some are going to take 10 hours or maybe more. When people tell me they took a dose at bedtime and they're still high till noon the next day, you're a slow metabolizer. So you're not only going to need it maybe once a day. So you have to adjust your treatment plan based on individual metabolism.
What's the solid line?
The solid line is called carboxy-THC. It's what the THC is turned into by the liver, and it is no longer active. It's gone. It lingers. The only one it's good for is law enforcement. So we have some products on the market. The government would love to be able to just say, hey, you've got cannabis on the market. Just use these. Well, they're individual molecules. This is synthetic THC. This is synthetic THC. This one's the new arrival on the block. Cannabidiol as a CBD dominant whole plant extract. GW Pharmaceuticals is the English company that's doing that trial on the glioblastoma brain tumor, but they're also the company that makes this product, cannabidiol. And what they say is, we can't get the THC out. We try, but it's still going to be about 0.1, 0.2, maybe 0.3% in this product. It's 99% CBD and it's 1%, they say, non-THC cannabinoids, but the truth of it is THC is still there. They just can't knock it all out. It's pretty good for seizure disorders, but again, the whole plant works better than the CBD alone. Quite differently. We don't allow cannabis, we don't allow the plants, the flowers, the extracts, This is another one of these GW pharmaceutical products. It got to phase 3 clinical trials, and then they raised the bar and said, okay, we want to give it for pain for terminal cancer patients. And it didn't test well in that situation, so they've delayed the approval of this product for the United States. It's available in 30 different countries. Canada and most of the places in the quote civilized world have this product, but we don't have it in the United States because we vilify THC. THC is the bad guy. And there's not really any logic to it when you look at the evidence, but we'll get to that. So we've got, I did that already. Smoke and vapor bioavailability. This is about how much of this actually gets into your system. Good to know about it. I'm not going to test you on it, but here's smoke and vapor. Bioavailability ranges from 2 to 56% in some of the studies. In another study, 10 to 25% actually ends up in your bloodstream. Well, you know what I'm talking about. Okay, that was maybe 5%. And then you just hold on to it. And you're going to get up to about 50% before you exhale. So you can get a lot of it if you make the effort. Oral forms, bioavailability in 3 different studies, 10 to 20% is in the bloodstream, 4 to 20% is in the bloodstream, and some cookie study where 6% ended up in the bloodstream. The liver's very efficient. It breaks most of these molecules down before they ever get into our bloodstream. So you ingest it, I don't care if it's a tincture or a brownie, whatever form it's in, about 80 or 90% of it's going to get broken down before it circulates in your bloodstream, yes.
If you have a really severely damaged liver, does that change the way it functions with cannabinoids?
I think there would be some point where it wouldn't be metabolizing as well, but practically speaking, it's not a problem with liver disease and breaking these molecules down. There's usually enough left of the liver to be able to have enough of these cytochromes to break down these medicines. As you probably know, or if you're in the medical field at all, some drugs have to be reduced dose when you're treating somebody with severe liver disease. And I think you would behave the same way if you're using cannabis as a medicine. Yes, sir?
Yes, sir. How would you compare the oral form versus topical for pain control throughout the night?
Comparing oral versus topical.
Yes.
This is an interesting question that I don't have the answer to. I do know that patients for many years have been telling me if they take cannabis as a topical, usually it's an extract, like an alcohol extract, and they'll rub it on their joints, on their shoulders, their knees, and some people say it's dramatic, it really knocks the pain out, and other people just say, man, it doesn't do it. Right. I think when you get to deeper areas of pain, like in this lumbar spine, the problem might be 3 inches deep in there where the herniated disc is, or the spinal stenosis. It's so deep into the body that those molecules don't really get there. Whereas if you're rubbing it around the knee, it's getting absorbed into the skin and affecting those pathways coming from that area of your body. So some people get a dramatic effect with topical use. Other products are being designed as transdermals, but they really need a vehicle to get across the skin, because otherwise the skin is a barrier to these molecules getting into your body. Suppositories is a whole other subject, and I'm not sure if we have the time to talk about it. Well, I'll talk a bit about it. Dr. Mahmoud El Soli runs the Mississippi farm for the federal government. He's our only licensed grower of marijuana for the United States research. Nice guy, but he's cornered the market. What El Soli did was got a contract back in 90 and 91 to see how well cannabis THC got into the body from a suppository. So his first product was various vehicles, coconut oil or cocoa butter rather, PEG, polyethylene glycol, these molecules that are designed to be stiff at room temperature to make a suppository. And then he put THC in it, and then he measured the blood levels in the animals that were tested. He tested monkeys and he tested dogs. I think they were beagles. And what he saw was 0 of the THC got absorbed. None at all. So this confuses me because people will use cannabis suppositories and get a good clinical effect. Most people, not all, will say, I don't really get high when I use it as a suppository. To me, that means you're probably not absorbing very much into the systemic circulation. There's this watershed in the rectum between the vena cava blood coming back from the legs and that portal vein that takes everything from the GI tract to the liver first. So that's the watershed right in the rectum. So some of it's going to get into that pathway and some of it's going to get into the liver and then into the bloodstream. I don't care how it gets there, which way, either the vena cava or the hepatic circulation, it is going to get into the bloodstream. And if you don't feel it, you're not getting much cannabinoid. What El Soli went on to do was design some compounds that made it better absorbed. And he found one called THC hemisuccinate, which is kind of like a prodrug. When you bound those together, it gets absorbed nicely across the rectal mucosa into the bloodstream, and then it's cleaved in, and now it's THC. So he was getting about 70% absorption in bioavailability. 70% was ending up in the bloodstream of the test animals. So we know we can make molecules that are well absorbed, but nobody really knows what we're doing yet because these tests haven't been done and published. Yes?
So I can tell you, I've been using cannabis, a body butter that I make with cannabis vaginally and rectally for over a year now, with a high THC compound.
Ratio?
And I don't get high, but I will tell you my vagina gets very inviting. And I can really, my vagina gets high. And I transformed the tissue in my vagina from atrophied and painful to folded and moist in a month. And I'm healing hemorrhoids with it. So I think it acts where it is really effectively. I don't know about, again, above the waist, but it doesn't matter.
Well, thank you for sharing that. Seriously. You know, there is an animal study which shows that the lymphatics end up with a lot of cannabinoids in mice. So if you put a suppository in a mouse, it'll end up in the lymphatics. So there's things happening, we just don't have measures. Okay, moving along. So what about harm? This is the big topic. This is what we're showered with from the government constantly. They don't like what's going on, and the drug war is alive and well. Millions of people use cannabis with little evidence of harm. There are no deaths from cannabis overdose. There's a paucity of serious side effects. Decades of research have failed to show significant and irrefutable harm with cannabis use, and cannabis and cannabinoid research for therapeutic uses remains largely prohibited. So, you know, this is where we are in this country. Sad but true. Now, what about pulmonary harm, fetal harm, neonatal harm, brain development, addiction, psychosis and schizophrenia, and impairment? These are certainly some of the hot topics that you find in the news. Let's take them one at a time. First of all, pulmonary harm. My mentor is Donald Tashkin, Professor Emeritus of Pulmonary Medicine at UCLA. He's been on the payroll for NIDA, National Institute on Drug Abuse, for 45 years, trying to show the harm in smoking pot. I say trying to show. There's not much. It does irritate the airway. It causes increased mucus production. There's some cough and inflammation and edema of the airway. If he looks down there with a scope, he sees it's a little pink and puffy. But what about COPD? What about emphysema? What about seriously harming pulmonary function? It doesn't do any of that, even in the heavy chronic pot smokers. So it's very interesting that it doesn't cause that kind of harm to the lungs where it is an irritant. Clearly it is an irritant. People cough, they don't like it, they don't want to use it that way. But somebody told me before the talk tonight that one of their loved ones was using cannabis for lung cancer, smoked only for 14 years. Wow. That's unusual for lung cancer. and getting it right in there where the tumor was. And so it was probably doing something. Yes?
Excuse me, there are some studies about smoking dab oil, these new extractions, and to the lungs, to...
Not sure if I understand your question.
Dab oil.
Oh, dabbing.
Sorry.
Okay. Dab, for those who don't know, is just to take the very concentrated oil and put it on a hot item and inhale a big dose. It's like you get a whole joint in one breath. It's kind of a recreational phenomenon, mostly in the young people. I have a rare patient who will tell me they like using it for pain control because it's so fast. Dabbing is otherwise, I think, a bit on the dangerous side because people will faint and fall over and hurt themselves, crack skulls, break shoulders, all that kind of thing happens when the dabbing stations are set up at the cannabis conferences. Seriously. John?
Never happened to me. I dabbed every day for 3 months and got on a bicycle and rode and never had a single problem.
Thank you for that. Dabbing never affected him, and he's here to tell the story. So no COPD or emphysema, but then he needed to show whether or not it was causing cancer. And when he showed NIDA that the tar in pot was just essentially the same as the tar in cigarettes. The only difference being the nicotine in the cigarettes, the cannabinoids in the pot. So NIDA said, that's all the evidence we need, pot causes cancer. And he fought them. And his superiors at NIDA said, nope, you're not going to do the research. So he went over their head until he got somebody who said, okay, you can do it. He had over 1,000 people with cancers and over 1,000 controls, often from the same block, the same occupation, really a well-controlled epidemiologic study. And he showed that there was no substantive evidence of an increase in the incidence of cancers in the lungs, trachea, larynx, pharynx, or esophagus, even in the heavy pot smokers. So it does not cause cancers of the lung. And in those patients that were smoking pot and tobacco, in that cohort, they had a 37% decrease in the incidence of their lung cancers.
From other smoking populations? Tobacco smoking?
Yes, that's right. So there's a protective role of these cannabinoids when they are inhaled. Now, here's a 95 study, and basically what they got down to was saying marijuana use was relatively common and not related to adverse pregnancy outcomes. This was published in the Journal of Obstetrics and Gynecology in 1995. I don't need to belabor that. 20 years later, we're asking the same question. Here's a 2015 study. Maternal marijuana use during pregnancy is not an independent risk factor for adverse neonatal outcomes. It's kind of a complex jargon to mean it didn't cause any problem. Thus, the association between maternal marijuana use and adverse outcomes appears to be attributable to concomitant tobacco use and other confounding factors. So tobacco and alcohol are a big problem. When you exclude those, the cannabis was not causing any problems with the pregnancies. Next study, GYN, 2016, a year later. This was a meta-analysis, and they looked at 24 different studies. And they concluded in their review that women who smoked cannabis use during pregnancy had an increase in the odds of anemia. Now that's the lead story in this study. 24 papers. 4 of those papers actually looked at the hemoglobin during the pregnancy, and only 1 of those had anemia, and they didn't test for anemia before the pregnancy. So now it's a headline and it's meaningless if you really want to read the story. Okay, get the picture. Here's another story by Chabaria in 2016. And again, cannabis alone was not associated with adverse fetal or maternal outcomes, including maternal asthma, preterm birth, lower birth weight, and maternal pregnancy. Related hypertension, I should say. You know, we look hard for harm, and if there was really something harmful happening in pregnancies, we would have known about it a long time ago. And I think if you're going to look at birth weight very, very closely, you might find that there's maybe 100-gram difference between a massive number of babies born to pot-smoking moms as compared to normal corn-fed moms. So there may be an effect, but it's not a big deal. It doesn't seem to really harm the infants. So Melanie Dreher is the only one who really did a serious study to look at this. She went to Jamaica as a graduate student, a student of Margaret Mead's, I might mention. She went as a graduate student, spent 2 years in Jamaica living with the Jamaicans and followed women who were pot smokers through their pregnancy. She found a group of controls. She started with 30 and 30. She ended up in the study with 24 prenatal cannabis exposed newborns, and they did better than their matched cohorts. This got published in Pediatrics in 1994. When she went back years later to show how those same kids were doing, and they were still doing better, Pediatrics didn't want to publish it. Brain injury, big topic. The head of NIDA says that this is going to permanently damage your brain. Short-term memory impairment has been observed after heavy chronic recreational cannabis usage, but virtually disappears after a few weeks of abstinence. This is not a pro-cannabis guy, but that's the facts. More recent studies similarly encouraging regards to reversibility of cognitive sequelae. So if you feel like you're using pot and your short-term memory is kind of impaired, yeah, it may be a little bit impaired. When you're not under the influence of cannabis, that disappears rather quickly. It doesn't harm the brain. In animal studies, the animals that got the pot have a better brain in the end than the ones that didn't. They do better actually under the influence of these added cannabinoids. Here's another study. Lower grade point averages associated with persistent cannabis usage in high school pupils lost statistical significance when controlling for concomitant alcohol and tobacco usage. So again, you separate them. The government loves to put them all together and say, it's the pot. Well, it's not the pot. When you separate out the pot, it's not causing the harm to lower grade point averages. And then cannabis usage alone is not found responsible for IQ or performance differences in teens, again, compared to cigarette smoking and other compounds. So one study after another, if you really look at the data, cannabis is exonerated over and over, and we end up blaming alcohol and tobacco for the risks of any impact on the brain. Now, there's some more specific data that has been done in imaging the brain, and with these new MRI scanners getting really detailed images, the government has felt that it was worth the funding to see if we could see a difference in the way the brain's developed under the influence of pot-smoking teens. And so these studies are addressing that issue. Gilman in 2014 in a NIDA-funded study made some strong comments about this. The data suggested that marijuana exposure, even in young recreational users, in a 20-subject teenage pot smokers were evaluated, was associated with exposure-dependent alterations of the neural matrix of core reward structures and is consistent with animal studies of changes in dendritic arborization. Not that.
What does that mean?
Well, it basically means it's a frightening comment to say that the brain's not developing the same, that the structures in the brain are actually abnormal in shape and size. That's what it's all about. Now, what happened is, in the body of the paper, she exposes the fact that the exposure to alcohol may have been affecting the brain structures. The participants didn't meet criteria for alcohol abuse or dependence, but compared to the controls, they were using more alcohol. So NIDA funded another paper that came out the next year. That's the same paper. That's Gilman. Here's Gilman. I'm going to go on to Weiland in 2015. This said, okay, we got to control better for alcohol. So now they get 29 adults and 50 kids and their controls, and they analyze these brain structures. And in the end, what they found was this, that there was no statistically significant differences found between daily users and non-users on the volume or shape in the regions of interest, namely the nucleus accumbens, amygdala, hippocampus, and cerebellum. These structures did not have any differences when they controlled for alcohol. Again, it's the alcohol that they're pointing to. And she makes a strong comment in the end of the paper, and I kind of enjoy reading it. Effect sizes suggests that the failure to find differences was not due to a lack of statistical power, but rather was due to the lack of even a modest effect. In sum, the results indicate that when carefully controlling for alcohol use, gender, age, and other variables, there is no association between marijuana use and standard volumetric or shape measurements of those subcortical structures. So generally speaking, I think most of the papers coming out are showing that we don't see any changes in these brain structures. And in a paper that came out about a year later from Kunders in the Netherlands, again, but this one was a longitudinal study of subjects. No significant gray matter changes were observed in the cannabis users. So I'm feeling pretty comfortable about a lack of change. Now, let's be realistic about this in another way too. What about the kids that are never going outside and always on a video game? What about kids that are doing a lot of other behaviors? Are we comparing their brain structures to kids that are climbing trees in sports programs or have pets, like horses or whatever? No, we're not doing that. We're trying to find some dirt on cannabis, and they're having a hard time doing it. Here's another case report that I wanted to give to you. This kiddo, and I showed this last year when I spoke here, this kid presented with his parents when he was 16 months of age with a large brain tumor. He had begun to cross his eyes and he looked like he was in pain. They took him to Children's Hospital of Oakland. They scanned him the same day. He had a big brain tumor. There it is, right there. August of 2001, 3 views of it. Okay, there they are. 3 months later, what the folks said to the doctors was they talked to the surgeons, they talked to the chemo docs, they talked to the radiation oncologists, and all of them said, the surgeon said I wouldn't operate on that tumor. Thank God. The oncologist and the radiation docs said, we've got a treatment for you. And they admitted that it's not going to kill the tumor, but it'll reduce the volume of it, and there will be some collateral damage to the brain. So, they were honest about it, and the parents said, thanks, we'll think about it, we'll get back to you. They came to me a couple days later. And we started putting that full extract oil on his pacifier twice a day. After, a mid-morning nap and again at bedtime. Pretty good squirt of the oil, somewhere between 25 and maybe 50 or 100, even 100 milligrams of cannabinoids. Pretty big dose. Started off with THC back in 2011 when we didn't have a lot of CBD around. There's been a trend to go to more CBD. Currently, he's using a 1-to-1 at bedtime of THC and CBD, and he uses a high CBD before the kid goes to school. You can see that by 3 months, the tumor was fading. By 5 months, the tumor was virtually gone. And today, there's no recurrence, and he's still on the cannabis therapy. A 3rd grader, he looks great. He sits at the table, and he tells me all these stories about school. He's such a sweet kid. I just am tickled every time I get to see him. They tested his IQ when he went into the 1st grade. It was 135. The prohibitionists would say it was probably 150, and now it's 100. So the NIDA director, whose name I won't mention, is often quotes a surmised neurotoxic effect of cannabis on the developing brain that permanently lowers IQ. This study was reviewed at the University of Oxford and finds the conclusions premature in light of likely confounding from socioeconomic status. This is in a study out of southern New Zealand, and the kids had all kinds of problems in this cohort, and she ended up blaming the cannabis when it really shouldn't be. Addiction, the only thing I really want to say here is people get a choice between going to jail or going to drug rehab when they're arrested for cannabis use. And if they go to drug rehab, they're called an addict, and that going to drug rehab is what they need to do. And so 9% of ever cannabis users are considered likely to become dependent on cannabis. Well, for me, if cannabis works, then I don't call that addiction. And you might use it. We don't talk about that with aspirin and ibuprofen and acetaminophen and any other drug, that you're addicted to it if you take it regularly because it helps your pain. We do for cannabis though, and that's big business in this field of addiction. This is where a lot of the money goes. Psychosis and schizophrenia. I like going back to a basic study, and I say that the association between cannabis and psychosis or schizophrenia does exist. It depends on your perspective. If you're a parent of a kid who at 15 starts smoking pot and by the time he's 18 he's got schizophrenia, you're going to probably point to the marijuana and say it was the pot that caused the schizophrenia. Well, the kid was probably self-medicating, and I agree with that notion, and he probably felt better when he used cannabis. But here's a study that, there's two studies shown on the table here. One of them is that between 1972 and 2002, the UK saw an 18-fold increase in the use of cannabis in their 18-year-olds and younger, while there was a 4-fold increase in the use of cannabis in their adults. And overlapping with that, but not entirely covered by it, the UK studied the incidence of schizophrenia and psychosis in their clinic system. So this is Northern Ireland and Scotland and the UK and Wales. All those clinics, 2.3% of the UK population was evaluated over this decade, almost 600,000 patients per year. And they looked at all the diagnoses of schizophrenia and psychosis while there was this great rise in the use of cannabis. And they concluded that the incidence and prevalence of schizophrenia and psychosis were either stable or declining during that decade of 1996 to 2005. So we don't really have evidence epidemiologically that we're causing schizophrenia with cannabis use. Driving impairment, it's quick. I'm not going to read this stuff, but suffice to say that marijuana doesn't significantly change mean driving performance in most of the studies that have been done. You can design a study where you can show that somebody smoked pot might run into a cone or something out in a test field. But overall, there's not a significant risk in having cannabis on board and in your system and your capacity to drive. And what I want to make a bit more of a point about here is the difference between a neophyte, somebody who's new to cannabis use, and somebody who is a chronic cannabis user. There's a big difference between those two. The ones that are used to it drive quite well. And this lower part of this story, a study done in 2010 was done by the National Traffic Highway Safety people, and Ray Maker reported to Congress about these results, and basically what he was saying is that the people that are heavy pot smokers were good drivers. So it does not really end up being a significant problem. Yes?
My son, he does cannabis every day. He's always gotten the system. He's the best driver who drives me, and I'm just totally impressed by his judgment, his patience, his non-reactivity, his skill, his alertness, and he teaches me while he's driving his steam on. He does all these.
So thank you for the anecdote. The lady here tells us that her son smokes pot all the time and is an excellent driver. I think this fits with the evidence that we see in the driving tests. So where do we go from here? We got a harm model that is where the money is in the United States. We have a therapeutic model that doesn't really get its due credit and isn't being studied. We drafted in California our Prop 215 back in 1995 and 6 and ended up voting on it. credit Todd McCorea. Well, it was Todd McCorea, one of my mentors, a physician in the East Bay. I could tell 10 minutes the story about him, but I won't. Dale Geringer, who's the head of California Normal, Dennis Perrone, who ran the pot clubs in San Francisco, William Panzer is an attorney in Oakland. They drafted the ballot initiative, credit McCorea, with the phrase, any other condition for which cannabis provides relief. So we get to use cannabis for anything that it provides relief for in California. Of course, we've gone past that with adult use now. Credit Soros and Lewis, Peter Lewis, billionaires who funded the signature drive. That's where the money came from. There's the night of the election. It passed by 56% of the votes in California. This is Dennis Perrone, and the feds were stunned. They had no idea that this was going to pass. And within a month, here's Barry McCaffrey. He's the head of the ONDCP, Office of Narcotic Drug Control, ONDCP Protection. Here's Donna Shalala at Health and Human Services. HHS holds the patent on cannabinoids. And off the screen over to the right is Janet Reno, the AG, the Attorney General at the time under the Clinton administration. And they said that they would take the doctors' DEA licenses away if they approved cannabis in California. It took a federal injunction to stop them, and you know the rest of the story. So, the greatest harm from the use of cannabis is getting caught with it. That's true for the kids now, but not so much for the adults, unless you're smoking in public, and then we have to consider that. But these agencies are really behind the misinformation that comes to Americans. Arrests for cannabis use and sales continue at a rate of about 750,000 arrests annually for marijuana. More citizens are incarcerated in the United States, and in many cases because of drug charges, than anywhere in the world. That is a sad fact. And the prison population today is 2,400,000. Looking at this graphic, this red mark would be up to the end if we hit 2.4 million people. So here's Nixon right here. This is the beginning of the drug war, and this is what we've done to the Americans, is put them in jail and taken their rights away from them. This is the state map today. I updated it since the election. We got Utah now as a medical marijuana state, Michigan became an adult use state, and Missouri became a medical marijuana state. So there are only a few left that don't have anything at all, and the pale green ones are the ones that have CBD. And CBD is available in most of these places where you can go into shops and get CBD. Again, it's not single molecule CBD, but it's a whole plant CBD, and it has nice therapeutic properties. It's not as good as the whole plant, and when you get more THC in it. So, citizens have changed the world. They've changed by the laws and the ballot initiatives. It's been only New Hampshire that changed it in their state house. Otherwise, it's been ballot initiatives on all of those states. Ballot initiatives. It's the public that changed it because they knew what you know. Despite the fact that most physicians are unprepared to counsel their patients about cannabis, many people are using cannabis, and I encourage my patients to talk to their doctors about it and let them know what it's doing for them. The international laws and the state laws are changing while the federal cannabis prohibition is unyielding. This started back in 2012 with the opium issues. China, France, Germany, Great Britain, Persia, Italy, Japan, eventually 12 nations in all signed on to the Opium Convention. So there was an international effort to stop some of the opium use and trade. In '61, this one is from Harry Anslinger, and those of you who know the story about Anslinger, it's kind of a sickening story, but he became our drug czar back in the 1930s and ended up not retiring until after this point, in about 62 or 3. So he went to the UN and got this single convention narcotic treaty, which cannabis is part of, so that all but 8 nations that did not sign on have agreed that cannabis is basically illegal in those countries. That is changing now. We have other conventions since then in '72 and again in '88. These are also international conventions adopted in the UN, excluding 11 nations here and 10 nations here. But today we've got Canada that legalized last a month and a half ago. South Africa allows cultivation of cannabis. Uruguay is legal, but they only allow it through government sources, which kind of sucks, and they can even tell if it's marijuana that was grown by their federal government. So if you're caught growing your own, you're in trouble. So it's not exactly legalized. Decriminalization is happening all over the world. There's a few scary places like Singapore. You don't want to go to Singapore or pot. And some other places too. But many of these countries where it's decriminalized, it's quite safe at this point. Now, this is an interesting little story. There was a paper that came out about 4 or 5 years ago, and they felt that it was necessary to modernize the WHO's, the World Health Organization's view on what about cannabis and its extracts. So they found that they really felt that it needed to be reassessed. We argue that assessments do not have unlimited validity, and therefore substances need to be reassessed periodically. So the WHO is working for the UN to evaluate cannabis, and they're reporting to the UN. And the issues that here's who's on that committee, 11 members on this ECDD, which stands for Expert Commission on Drug Dependence. The committee today is made up of people from US, Canada, Nigeria, India, Canada, Australia, UK, Iran, Thailand, and Japan. These are mostly addictionologists and specialists in, here's an anesthesiologist, but they're drug dependency people. But they are also, I think, I'm hopeful at this point. What they did was they looked at these 5 categories. CBD as a single plant extract, as a single molecule, and cannabis as a plant and its resins, extracts and tinctures, plain old delta-9 THC, and then the isomers, which would include various synthetic molecules as well. They're analyzing these 5 categories, and right off the top, they looked at CBD and said, the committee recommended that preparations considered to be pure CBD should not be scheduled within the International Drug Control Conventions. It's already been told to the UN. It'll be February before they reveal this. This is in a letter between the WHO and the UN. These other 5 categories, the plant and its resins, the extracts and tinctures, the delta-9 THC, and the isomers, in all cases, the committee concluded that there is sufficient evidence to proceed with a critical review. So at least they're giving it a more serious look to see, are these really dangerous molecules, and should the UN be involved in banning them? So, I'm almost done. Limitations and precautions. Yes, adverse effects do occur with cannabis use. Woozy, dry mouth, loss of balance, spacey, sleepy, reduced, I abbreviated, short-term memory, and reduced cognitive abilities. The more chronic you are, the more you get used to it, and you may not show any significant impairment. But certainly people that are kind of new to it will be more impaired when using cannabis. These other adverse effects, they exist. They're not terribly problematic, but it's an individual thing. Overdose can result in anxiety, and we talked about this earlier. In CBD, and I guess I didn't put that, yes, I did put that slide in. Remember when we talked about single molecule CBD different from whole plant CBD? In this case, there is a biphasic response with CBD, with a small dose doing nothing, a big dose, a moderate dose doing a lot of pharmacologic benefits, and a bigger dose, you lose that effect. That's a biphasic effect. That may exist for THC, but it's not shown in the same way as far as studies go. What we do show, though, is that people can use cannabis and reduce anxiety, but if you get an excessive dose, you may get very anxious and find quite a lot of dysphoria associated with an overdose. Sometimes panic, falls, and rarely fainting. Smoke and vapor do cause the bronchial irritation. This hyperemesis syndrome does occur. My patients admit to about 5 or 6 of my patients out of 3,000 say they've had this
What is it?
hyperemesis syndrome. It means you're using cannabis on a daily basis, and then fairly suddenly you'll start vomiting and can't stop vomiting. You vomit over and over again, you'll get dehydrated, you end up in an ER. The big city ERs are seeing quite a lot of it because they're dealing with big populations, and it happens.
I've heard it's the name and not the way you put it.
Well, that has been suggested that it's some of the pesticides that are used on the plant rather than the cannabinoid activation chronically that is changing something, and that hasn't been figured out yet. So I've heard that too, and I don't know whether it's true or not. It's something to keep an eye on.
Worse also with synthetics.
Worse with synthetics? Yes, that's absolutely true. The synthetic cannabinoids can be quite dangerous. They bind, in many cases, much more strongly to the cannabinoid receptors. During the Kennedy administration, they were exploring the use of synthetic cannabinoids as weapons. And one of my doctor friends in Santa Rosa was the physician who led that program. He tells quite an interesting story himself. So what they found was this: when they gave these synthetics to the Army volunteers, they couldn't stand up. They had to stay on the floor, otherwise they would faint. It was very powerful. So synthetics can really overwhelm the cannabinoid system, and it's quite an interesting phenomenon with the synthetics. They can be dangerous, and people have died from them as well, maybe in conjunction with other chemicals, but it is a problem. Acute psychosis. This happened once in my practice. Well, it wasn't in my practice. It's a friend of the family. Took an overdose orally and ended up with acute psychosis. Was crazy for a week. Admitted to a hospital, and then it cleared up. So it does occur, and I think it's reversible. The hyperemesis is reversible usually in a matter of hours. Feels good to take a hot shower. That's kind of a tip-off that we're dealing with hyperemesis. Somebody comes in with chronic, constant vomiting and says, I feel better when I'm in the shower. Well, they're probably smoking pot. When you let the receptors normalize and the cannabinoids come out of the receptors, they're better in a matter of hours and actually can go back to regular use of cannabis again. Limited access to products is a problem, and as we go into this new era, there's some risk of discovery. People can get fired in the workplace if they're positive for cannabis. It's sad but true. We need some more workplace protections for people who use cannabis medicinally or recreationally, because there's no protection. When we go to the dispensaries, we've changed everything as of January. You can go into dispensaries as of July 1st. Everything had to come off of the counters and be replaced by products that were properly labeled and packaged in child-proof packaging. We've paved the way for the big corporations. It's kind of sad. We've knocked out about 99% of our growers in California. There's some wonderful medicine makers throughout our community and throughout our counties in Northern California, and I just wish they could share their wares with our dispensaries. But until we change the law, that won't happen. Yes.
Any ideas or resources for homebound, low-income folks that can't get a medical evaluation, that sort of thing?
So not even about medicine, but getting an evaluation?
Well,
for both?
For cannabis.
Uh-huh. Well, I know of one fellow who's making it available to children with seizure disorders, free medicine. His organization is called Caladrius. It's a Greek myth about a bird that comes to the house of somebody who's sick, and when the bird leaves, it takes the illness away, or something like that. His kid has one of those, I think, Dravet syndrome, and he started providing for his own child and then became aware of the community of other people with the same problem. And so he's making free medicine available to the kids. I do some discount in some patients if they have need. There are a lot cheaper people than me. You can go online if you need a medical recommendation or a medical approval or some counseling. But generally speaking, if you talk to everybody around this crowd, you would find medicine makers who would share medicine. Yes, sir.
Thank you so much. This has been great. Do you have any information about the treatment of ADHD?
It works great for ADHD. I've been treating ADD and ADHD for a long time. What happens is I see moms bring in their kids after they've been tried on conventional medicines, and if they're not faring well and they start having suicidal behavior and thoughts, moms panic and say, I gotta try something else first. I've seen it focus a lot of kids with ADD and ADHD. It's remarkable how well it works. I tend to use oral products rather than smoke products. When I first started approving it 15 years ago for ADD, it was smoked, and they would come home from school and take a puff, or take a puff at bedtime, or when they were doing their homework, and it helped them to focus. We've gotten more sophisticated in it. We can go to CBD, and we can go to THC and CBD blends, and we can use medicines that are going to be good in the daytime. It's a problem when sending medicine to school. I really encourage people to try to not do that. I can tell stories about it.
Yes.
Yes.
I just wanted to back up a few slides. We're talking about states that were legalized marijuana. I just found out yesterday online that the little country of Luxembourg has legalized it. And that came out of Amsterdam, and they said we thought we would be the first in the Netherlands. So Luxembourg gets that honor.
Very nice. Thank you for that information. I'll have to add it to the slide. Yes.
So you mentioned Onfi as being one of the drugs that they know is a problem, but are there any other drugs that have bad interactions?
Generally speaking, I encourage people on any anticonvulsant with high doses of CBD to get their blood levels checked.
What about prednisone?
I don't believe it has an effect on prednisolone. No, I don't believe so. Yes, sir.
There's been some discussion about the role of molds.
Molds.
You know, we're in wine country, right? There's molds that affect the grape harvest. Those same things can end up in the flowers. Yep. Right?
Well, yes, it certainly can.
That way, it's difficult to see. Has there been anything discovered as to issues that have come out of that yet?
Well, two quick answers to the question of molds and any risks of molds in cannabis. One is, when I asked Dr. Tashkin, the pulmonologist, about whether he's seeing people with molds who are in pulmonary infections, he said that he thinks the only risk would really be in the immunocompromised patients, cancer therapy patients. But otherwise, he's not seeing it as a significant risk with a little bit of mold. Now, we do know that this is one of the tests that cannabis has to go through to be sold. And so it is getting analyzed in the laboratories for mold, and it gets thrown out. One of the persons that I know who lives in the West County has a big field out in the Central Valley, and they ended up with mold out there, and the whole field was thrown out because it didn't pass the test.
There are people, though, that are sensitive to mold, and so if that ends up being that they take, ingest, or get around mold, they are more reactive to that. And there's HLA-DQR, actual genetic testing that you can check that out. So
Thank
those
you.
people, it's an issue.
Yeah, that's a good point. Yeah, some people are very sensitive to molds.
Question?
Yes.
Is there any correlation or connectivity to Coumadin interacting with cannabis?
There's a paper about Coumadin and cannabis that came out a few years ago, and it actually showed that it didn't cause increased blood thinning, but actually went the other direction. So it didn't really support the contention that it was a problem per se. Otherwise, I have not seen any significant cannabis and anticoagulant or Coumadin adverse effect. Do you know of any? No, haven't heard of any. Yes, sir.
A question regarding joint pain and anti-inflammatory properties.
Yes.
The role of different delivery systems, oral versus smoking, vaping versus topical, and also CBD versus THC, and the role of joint pain and anti-inflammatory issues.
Well, for those who might not have heard, the question is about inflammation in joints and joint pain, and what about THC, CBD, and the relationship or ratios of those. For my practice, CBD is not very potent when it comes to pain and inflammation. You really need some THC there. I generally aim for a blend of 1-to-1 as a point where you really get a much more significant effect as an anti-inflammatory. It tends to work very rapidly for pain relief inhaled. Honestly, that just happens to be the way it is in practice. Oral methods of administration are quite effective as well. Topical is, like I mentioned earlier, kind of, it could go either way. A lot of people don't get joint pain relief or significant anti-inflammatory effect from topical use, where I would suggest to them to use it orally primarily or inhaled secondarily as a good choice. Depends on the severity of the disease, and a lot of times using both inhaled and ingested forms, I think, could be best. Yes, sir.
I'm looking for a reliable source of seeds or starts for CBD strains. You know, when you look at the vendors at the Emerald Cup,
yes,
there's hundreds of them. And who knows what they've, come up with. And so any ideas about how to proceed?
So the question is about sourcing CBD seeds, seed lines. I think our British Columbia neighbors and our Netherlands friends are reliable in terms of selling us seeds. They're overpriced, but I think they're reliable. And I can't attest to anything over at the Emerald Cup. Does anybody know anything I don't know? No? Do you have a point?
No, I would agree with what you just said, that going online and
buying seeds is pretty safe and effective.
I was going to ask you, do you know what the difference between, say you have a CBD strain that's a 1-to-1, and taking, making oils with that, as opposed to taking, say you got a 7-to-1 or a 1-to-7 THC, it's a high in THC. Like I have a CBD strain that's 7-to-1 and I have a THC strain that's 1-to-7, or whatever. If you mix those and you make a 1-to-1, how would that compare to taking hemp-derived CBD and mixing it with the high cannabis strain and making it a 1-to-1?
You asked a very interesting question, and I do not have the answer to that. It was comparing the idea of mixing a 1-to-7 THC CBD to a 7-to-1 THC CBD, blending them and having a 1-to-1, versus taking a high CBD and a high THC and blending them and having a 1-to-1. I think what it really gets down to is what are we treating, and how relevant are the minor cannabinoids going to be to this question? So I can't answer that. It may be an excellent choice to blend your 1-to-1 and 1-to-7 and 7-to-1.
I'm not sure if you understood the question. I'm saying if you take not a synthetic, but a hemp-derived CBD and ended up taking a high THC strain and throwing in the hemp-derived CBD to make it a 1-to-1, comparing that to what I said before, two different. So
I made a point earlier in saying I can't draw the line in the sand between hemp-derived CBD and CBD plants that are 30-to-1 CBD.
They don't know yet.
We don't know yet. I think we just don't have the research.
So it's maybe trying that personally and seeing then would be a recommendation.
Yes, see if it works for those needs and try a different source if that one doesn't work. Now, because folks are drifting off, I'm available and I'll be happy to talk on, but I wanted to let people off the hook if they need to get going. I did want to conclude by the point that cost has become a big issue in our new dispensary world. I go a day in the clinic and say, I'm going to see about half of the patients knowing that they aren't going to be able to afford what I want them to take. It's really disappointing. So I'm encouraging them to get used to the idea of maybe using a full plant extract, a very concentrated extract, because it's more cost effective. Or I might say, you got to get online for growing your own medicine. Get used to the idea that you should be growing it or having friends growing it for you. So these medicines have become prohibitively expensive. Just the fact of the kids with autism, if they need 300 milligrams a day to quiet their autism down and make them pretty good students and helping them in so many ways. A 1 ounce bottle of THC tincture is about $75 to $90 for taxes. That's a daily dose. It isn't going to happen. Or cancer care, you get my point. It goes on and it's just way out of line. So, I think it's wonderful we can grow our own plants. Don't get me wrong, but I think we've really kind of screwed it up as well. Yes, sir.
In relation to making
tinctures?
Yes.
Whole plant extractions? You know, you read a lot, I've read a lot online, I trust you. What are your thoughts about decarbing herb before you're going to make a tincture to potentate the THC? Is that valid? Is that a real thing, decarbing?
Well, decarbing is real in terms of driving all of the acid forms out. So you're gonna, if you warm it long enough, you are going to decarboxylate it. And you know, some people speak of that as activating it. I don't think of it as activating it. THCA is an active molecule. CBDA is an active molecule. All of these acid forms have actions. So I think it gets into what we're treating and whether or not acid forms might be valuable in that particular treatment plan. So for my own interest, I would tend to make an infused oil out of cannabis that I grew in my garden without decarboxing. I just don't do it. And it makes a great product. It naturally decarboxylates. Heat does it for sure, rapidly. You can decarbox in the oven in an hour. But you can also get it decarboxylated just by having it exposed to light and air for a prolonged period of time. So it will decarboxylate. So, you know, those green buds are fine to put in your smoothie and you won't get stoned with that. But if they're dried, no guarantees. They may have decarboxylated sufficiently to be quite active. That is to say, already decarboxylated.
Plus you lose terpenes when you heat it, so the trade-offs to you are decarboxylating ain't all that good.
Well, or maybe not all that necessary.
There we go. Thank you.
I would suggest that. And it may depend on what I'm treating. I like using the acid forms in seizure disorders, in childhood epilepsy. I like using CBG in childhood epilepsy. I like exploring out into these other cannabinoids because I see better results when THC and CBD, or when CBD doesn't work alone, get the THC in there, or get the THCA in there, and so forth. Bring in the other molecules and experiment with them. Makes better medicines in many cases. You've been a great audience, and I really appreciate the honor of being here with you. So thank you so much for the invitation.
Thank you, Dr. Hergenrather. Everyone, don't forget we have another talk next month in January, January 23rd, Wednesday the 23rd. And I'm here to talk to you if any of you have any ideas about future lecturers, or if you want to volunteer to work with the foundation.
Thank you.
Thank you very much. You're welcome.